All right, we are going to cover Staph aureus. I'm going to highlight some of the important stuff that is probably already highlighted on here, but certain things you need to know about Staph aureus, and that is absolute must. You should be able to define Staph aureus, and the definition of Staph aureus itself is gram-positive, beta hemolytic, catalase positive, coagulase positive, cocci, which forms in clusters. This is the bare minimum that you need to know in order to rule out other bacteria that are going to be on the differential. They might give you some of these, they might not give you all of these. You also need to know the virulence factor, and the virulence factor is protein A. This is absolute must that you need to know about this bug as well. And the way protein A functions is that it binds to the FC region of IgG, thereby inhibiting complement activation and phagocytosis. I've seen that in different Q banks that they actually give you a picture of an immunoglobulin and identify. They have different areas labeled, and they say, oh, which area is there might be A, B, C, and they'll ask you where it does protein A work. So you need to know that. Uh, Staph aureus causes disease by two mechanisms. It's a toxin mediated or inflammatory mediated. And the inflammatory mediated is going to be skin infection, organ abscesses, pneumonia. Pneumonia is super important because they're going to give you a picture of an elderly or somebody in a nursing home, and they get the flu, they get treated, then all of a sudden they're sick again, and this time it's pneumonia caused by Staph aureus. It's a superimposed infection. You also need to know endocarditis. Now, endocarditis is caused by IV drug users, so they're shooting up through the veins. And it's important to know that Staph aureus is the most common cause of endocarditis associated with IV drug use, which often results in pulmonary infarction resulting from septic embolization from the tricuspid valve. The results in wedge-shaped hemorrhagic pulmonary infarction is hemorrhagic because the lungs have dual blood supply, which is pulmonary and bronchial arteries. The inflammatory disease also includes osteomyelitis. And osteomyelitis, which is an infection of the bone and bone marrow, can occur in three different mechanisms. It could be one, hematogenous seeding due to episode of bacteremia, spread from a contagious focus of infections as occurs in an infected diabetic foot wound, or direct inoculation of bones such as with a compound fracture or a traumatic injury. Hematogenous osteomyelitis occurs predominantly in children, particularly boys, and most frequently affects the long bones, which include tibia, fibula, and femur, are most often involved. Adults who develop this condition are more likely to have a vertebral involvement and frequently have a predisposition to bacteremia due to risk factors such as IV drug abuse or in developing vascular catheters. The presenting symptoms of hematologic osteomyelitis are vague, and a high index of suspicion is required to make the diagnosis. Initial symptoms such as malaise, fever are nonspecific. As the infection progresses, infants and younger children may refuse to move the affected extremities. Older children often complain of pain over the long bone and usually don't bear weight on the affected area. Bone pain develops as the abscess extends within the bone, leading to bone necrosis, periosteal disruption, and swelling of the surrounding soft tissue. Staph aureus is implicated in most cases of acute hematogenous osteomyelitis in otherwise healthy children. Staph aureus also causes toxin-mediated diseases, and it's important to know the toxins associated with Staph aureus. One is toxin-mediated disease, which is toxin shock syndrome toxin 1. The other one is staph scalded skin syndrome, which is an exfoliative toxin, and rapid onset food poisoning, which is caused by enterotoxin. It's easy to remember. Enterotoxin is the intestine, enterointestines. Staph scalded skin syndrome is caused by exfoliative toxin. You exfoliate the skin when you get a facial or something. What are you doing? You're exfoliating the skin. They will test you to know that which toxin does what. And they will give you a scenario. Maybe they have staph scalded skin syndrome, and they will list out about five different toxins. A couple of them might not be even associated with staph aureus. The other three probably will be. And you need to know that the exfoliative toxin does staph scalded skin syndrome. Um, let's go over the toxin mediated disease. In the toxin mediated disease, it causes toxic shock syndrome. Toxic shock syndrome toxin is a super antigen that binds to MHC2 and T cell receptors, which leads to polyclonal T cell activation. It's called a super antigen because, in contrast to usual antigen, which activates few helper T cells, it activates a large number of helper T cells. These toxins interact with major histocompatibility complex molecules on antigen presenting cells and the variable region of the T lymphocyte receptor to cause a nonspecific, widespread activation of T lymphocytes. Activation of T cells is responsible for the release of interleukin 2, interleukin 1, and TNF from macrophages. These interleukins cause capillary leakage, circulatory collapse, hypotension, shock, fever, and multi organ failures. How will these patients present? They're going to present with fever, vomiting, rash, shock, end organ failure, and elevated liver enzymes. And this is most commonly associated with prolonged tampon and nasal packing. I'm not sure if the STEP exam is still using this scenario. I know a couple of years they were using this scenario as well. And in comparison with group A strep, toxic shock like syndrome, which is associated with painful skin infection prior to syndrome. It can also cause staph scalded skin syndrome and is caused by the exfoliative toxin, which leads to positive Nikolsky sign, where the skin can easily come off or slip off by pressure. It is most common in infants and children, but usually not fatal unless the skin lesion becomes secondarily infected. Staph scalded skin syndrome is caused by circulating exotoxin. The bacteria can be elsewhere in the body, and the toxin can still cause damage. The way the exotoxin works is it works as a protease that cleaves the desmoglein in in desmosomes, which is right here. So they might even give you a picture, and I'm just highlighting the area, so you know you don't. So what you need to pick, if they give you a picture, you should be able to answer this question now. It also causes rapid onset food poisoning, which is caused by enterotoxin, and this is ingestion of preformed toxin. Food that most commonly associated with it is poultry, eggs, meat, tuna, chicken, potato, macaroni salad, cereal-filled pastries, milk, and dairy products. Um, Staphylococcus food poisoning. You can differentiate between staph and bacillus cereus, which is characteristically contaminated starchy food such as rice. Is usually reheated fried rice. Also, since the toxin is pre-formed, there's a short incubation period, and so basically from 2 to 6 hours, and it will cause non-bloody diarrhea. MRSA is also a very important bug that we need to know. MRSA stands for methicillin-resistant Staph aureus and is usually a community-acquired or a nosocomial hospital-acquired infection. And it's methicillin-resistant because of altered penicillin-binding protein. You also need to know that the most common causing nosocomial bloodstream infections are coagulase negative staphylococci, Staphylococcus aureus, enterococci, and candida. Catheters related infections should be suspected in hospitalized individuals with new onset fever. Also, the CDC recommends that if you are using a catheter, maintain hand hygiene with antimicrobial soap and alcohol based sanitizers along with sterile gloves. Use barrier precautions during placement of catheters, surgical masks, gloves, drapes, disinfecting the skin with chlorhexidine, and avoid femoral insertion sites. Promote removal of catheters when not needed. Guys, this is, I know you guys probably did not see this in many places yet, but this is being tested on the board. You need to know this right here. I've had friends that tell me that they got questions like this on the exam, so you need to know this whole thing right here. This is important because they might just ask you how do you avoid or what not to do. Also, very important is the resistance. Approximately 95% of Staph aureus isolated in the United States produces beta lactamase, which is a penicillinase, which causes resistance to penicillin. However, many Staph aureus strains, while resistant to penicillin, remain susceptible to penicillinase stable penicillins such as oxacillin, nafacillin, and methicillin. Strains that are oxacillin, nafacillin, and methicillin resistant historically turned methicillin resistant Staph aureus are resistant to all beta-lactam agents, including cephalosporins and carbapenems. Nafacillin resistance is mediated by alteration in the penicillin binding protein structure. Penicillin binding protein are the enzymes involved in cell wall synthesis. Altered penicillin binding proteins, particularly the 2B2A, they're getting very nitty picky on the exam, and particularly 2B2A have greatly reduced affinity for all beta lactam antimicrobial agents. And this should be it. You should go over this lecture once or twice. Um, Everything on this lecture is high yield stuff. I haven't put anything on here which I haven't seen in a test bank or ran into it in some clinical scenario. Everything on here is very important. So make sure you go over this couple times to get it down.